Thank you for invitation for great conference. I am Dr. Yoshinobu Murasato from Kyushu Medical Center, Japan. My topic is the role of imaging in bifurcation. Recently, Japanese and Korean bifurcation clubs published the consensus document in terms of coronary imaging in bifurcation intervention. We restate the roles of imaging in bifurcation PCI as follows. In pre-procedural optimal selection of devices and PCI strategy are important. First, measurement of dimension of lumen and vessel in member cell and side branch. Second, assessment of atherosclerotic plaque morphology, burden, longitudinal distribution, calcification, and negative remodeling. Third, detection of angiographically silent disease. Fourth, assessment of the risk of side branch compromise. In post-PCI, optimization of procedure is crucial for better clinical outcome. The following should be assessed in imaging. First, stent apposition. Second, stent expansion. Third, full lesion coverage by the stent. Fourth, stent edge dissection. Fifth, plaque prolapse inside stent. Sixth, side branch residual stenosis and dissection. Seventh, optimal guidewire recrossing before side branch dilation and subsequent adequate clearance of J-ring struts after side branch dilation. General practical imaging indexes for optimal PCI are also summarized in the European Society of Cardiology consensus paper. First, minimum stent area should be more than 5.5 mm² in IVUS and more than 4.5 mm² in OCT. Second, stent expansion index more than 80%. The stent edge should be located at the site of where plaque burden less than 50% and no repeatable. Malapposition should be limited less than 400 micrometer in actual distance and less than 1 mm in length. Generally, IVUS is useful for the detection of the external elastic lamina or actual plaque burden, while OCT is used for the detection of the repeatable, dissection, malapposition, and plaque protrusion. This is the actual clinical study comparing the angio guidance and OCT guidance. In the pre-intervention OCT changes strategy in 82%, mainly because lesion length, stent diameter, and finding of TICFA. In the post-intervention, OCT changes additional procedure due to stent malapposition, edge dissection, and under expansion. Sierra OPCA study is a randomized trial comparing angio and OCT guidance. In the composite endpoint of cardiac death and myocardial infarction, hazard ratio is significantly reduced to 0.44 in OCT guidance. IVUS has shown more evidence for its efficacy on left main intervention. In the main compare study from Korea, demonstrated that IVUS guidance decreased mortality. In the pooled analysis of around 1,000 patients, IVUS guidance showed higher survival free from composite endpoints of cardiac death, MI, and target lesion revascularization. IVUS guidance is also effective to reduce stent thrombosis. According to these practical evidence, current guideline for imaging guidance has been revised in the ESC guidelines. IVUS for left main and IVUS and/or OCT for stent-related mechanical problem are listed as Class 2A. In Japanese guideline, IVUS for left main and bifurcation is in class 1 and 2A respectively, while OCT for bifurcation is in class 2A. Recent innovation in the 3D OCT, which can visualize guidewire recrossing in the side branch and subsequent stent transformation by kissing balloon inflation. We conducted 3D OCT bifurcation registry in Japan and clarified the effect of ring connection on remain gel struts after kissing balloon inflation. We divided to the following pattern according to the existence of ring connection at the carina, ring-free and ring-connecting type. Once distal guidewire recrossing is achieved in the ring-free type, wide side branch opening is achieved, while in ring-connecting type, jet ring and strut remained even after distal guidewire recrossing and subsequent high-pressure kissing balloon inflation. We defined LFD type as distal wiring in ring-free type and investigated incomplete strut apposition. LFD type resulted in less incomplete stent apposition at the side branch ostium compared to non-LFD type. We also investigated success rate of optimal distal wiring in 3D OCT guided PCI. In first attempt, that means angial guidance, it was only 66%. Accumulating the attempt elevated the success rate to 87%. In the comparison between left main and non-left main bifurcation, success rate in the angial guidance is only 56%. It is very low. In the comparison between 2D and 3D OCT guidance in impact on incomplete stent apposition, in the left main bifurcation, 3D OCT guidance is more favorable than that in 2D OCT. This is an actual clinical case that 3D OCT guidance effectively worked for appropriate guidewire recrossing in two stenting. We treated this complex true bifurcation region in left main. We deployed the two stent with curl technique in both branches. This is a 3D OCT images after left main to L6 stenting. Guidewire recrossing point is the distal. It seems too far. However, link in the neighboring proximal cell has the risk of incomplete removal of the gel struts. Therefore, we dilated this cell. This is the images after left main to the LED stenting. Guidewire recrossed in the middle cell. The indicated point are too distal because the recrossed cell has the risk of limitation of expansion due to the existence of the ring. Therefore, we dilated the middle cell. Kissing balloon inflation and report were subsequently performed. Final CAG was acceptable. Final OCT also demonstrated wide stent expansion in both LED and L6 ostium and good stent expansion. In the one stent deployment in the bifurcation region, we definitely agree that routine performance of angial-guided kissing balloon inflation should not be performed, which is likely to result in more suboptimal results. However, according to the OCT follow-up studies, we fear the following. Are the gel struts in the sideband ostium really safe forever? This is a follow-up OCT study investigating the correlation between L6 ostium area narrowing and the gel struts number. There is a positive correlation which suggests that more gel struts promote more L6 ostial narrowing. Recently, FFO-guided sideburn treatment is proposed as follows. Even in the case with sideburn compliance after members stenting, preserved FFR more than 0.8 cell allows to leave sideburn treatment. Actual condition of sideburn ostium is indicated in the slide. Shifted carina is located in the sideburn ostium, and the remained lumen is still enough to tolerate myocardial ischemia. However, we know the condition induced by optimal sideburn treatment is much better. Shifted carina corrected to the neutral position and complete removal of gel struts. But we should know how often we perform suboptimal sideburn dilation. It is more than 60% in the angio guidance. Therefore, accurate assessment of guideway recursion point and subsequent stent deformation by sideburn dilation in 3D OCT facilitates more optimal sideburn treatment. Currently, we revise the classification of the gelling strut pattern and sideburn treatment strategy. In addition to link-free and link-connecting types, we newly involve the no or less gelling type. In the link-free type, 3D OCT guided distal wiring is strongly recommended. In the link-connecting type, 3D OCT guided distal wiring does not always lead to optimal result. More aggressive part may change the category to LF type. In no or less gelling type, we can leave it with confidence except for the sideburn compromise. The bifurcated vessel should be reconstructed according to vascular branching law to minimize energy loss and prevent low shear stress in the bifurcated area. Stent expansion is crucial to prevent target lesion failure. However, element 3 revealed the rate of stent underexpansion in which stent expansion index less than 80% was 59%. One of the reasons for higher prevalence of stent underexpansion was the definition of the vessel reference that was the average of proximal and distal references. Minimum expansion index is a proposed volumetric analysis obtained by creating an ideal lumen profile considering vessel tapering and branching using flow-Kasab model. A positive correlation between minimum expansion index and the post-PCI FFR is reported, and a minimum expansion index more than 73% corresponds to final FFR more than 0.86, which suggests no remained functional ischemia. This is an actual OCT analysis cases with long stenting across the bifurcation. Minimum stent area is 3.45 mm² that is located at distal member cell, but the expansion index is 89%. That means the stent is sufficiently expanded according to the distal member cell reference. Minimum expansion index is 67%, that is located at proximal member cell with stent area of 4.5 mm², which used to be considered as adequate stent expansion. However, it is inadequate for proximal member cell reference, which require more proximal optimization. Therefore, the target of post-dilation is changed from minimum stent area to minimum expansion index. This is a scheme of the imaging guidance in bifurcation intervention. In the pre-PCI, the imaging in both member cell and side branch is necessary for region assessment, device sizing, and the decision of side branch treatment. Second imaging is performed after members stenting and subsequent part to assess stent expansion, malapposition, and jailing strut pattern. After guidewire recrossing, confirmation of guidewire recrossing point by 3D OCT is recommended. After kissing balloon inflation or sideband dilation, imaging should be done to assess final stent expansion and apposition, deformation, and the necessity of additional treatment. Ladies and gentlemen, this is my conclusion slide. The accurate morphological assessment of the main vessel and side branch using an intraluminal imaging devices before and after procedure are important for optimization of the device during complex bifurcation procedure. Imaging guidance can provide procedural optimization, which lead to improvement of clinical outcome. Physiological stimulation using 3D morphological assessment has been available, and natural bifurcated vessel reconstruction according to the vessel branching law is important. Thank you for your attention.